Hi, Dr. Giri.
Hello.
Hi, how are you?
Good, good, good. Okay, so let me share the screen. Is the screen on for everyone?
Yeah, yes.
Oh, okay. Okay, so maybe we should just get started. Now, before I start any, thing from here, uh, are there any questions about anything related to breast that you would like me to talk even without any images?
Not that come to my mind. I don't know if anyone else
Okay.
has any questions.
Yeah, anyway, whatever comes up, please feel free. I mean, if I don't have really an answer at the time, I will definitely get back. But I think we can use this forum to address any issues that might arise.
Yeah, yeah, that will be really great. Yeah.
Yeah. Okay. So I was thinking that let's see if we can talk about lobular carcinoma in situ. So let me just put the search word in. There are a few things that I think are of practical importance when it comes to lobular carcinoma in situ. So why do I get only one?
You have to type lcis, I think.
Okay. Oh, there are many.
Just enter, just enter. That's
okay. Oh, okay. Here we go. Okay. So one, of course, lobular carcinoma in situ, we know they can come in different morphologic forms. There is the so-called classic type, which, we all deal with day to day. I mean, it's pretty common. And then there are the so-called unusual or special types of lobular carcinoma in situ. So let's see if we have some images of those also in this collection. If not, we will just have like a general discussion, and then hopefully at some other time, I can actually share my own, uh, you know, talk or something like that, and then we can discuss more about that. So here we have an image. It says lobular carcinoma in situ involving ducts. So I suppose they mean large ducts. So these are all lactiferous ducts. I mean, some of these are quite small. And as you can see, so this is classic form of lcis, which is involving a mammary duct. These cells here, which are pushing between the ductal epithelial or myoepithelial cells, these are the cells of lobular carcinoma in situ. Now, if you do the E-cadherin stain, you have to be mindful of what to look for, because a lot of these cells, obviously, these are all ductal cells. These will stain positive. So we have to look between those cells to look for the absence of E-cadherin. Otherwise, this can be confusing in certain situations. We probably will have some examples of that, and we will come to that discussion at that time. So in the interpretation of E-cadherin stain, there are a few things to remember. One is you should be aware that even in pretty straightforward LCIS, the lobular carcinoma in situ cells, the cells that form LCIS, they can kind of squish the native ductal epithelial cells. And those might stain with E-cadherin. And that will create some confusion whether this is LCIS or not, because you will kind of think, oh, could this be mixed LCIS, dcis because of E-cadherin? No, it's not like that. You have to morphologically recognize that those were the benign cells. Now, it's another matter if also the ductal cells within a unit of in situ carcinoma are also malignant. In that case, there could be grounds to make the interpretation that, yeah, this is mixed DCIS, LCIS. So, I mean, this concept is pretty simple and straightforward, but in some unusual circumstances, you have to keep that in mind, because otherwise you might make wrong interpretations. Okay, so now we have seen these ducts here. Some of these are not involved at all by anything. They are just normal mammary ducts. And then there is this one really large duct. So this also we have seen, right? I mean, we all have seen this, this presentation, Pagetoid extension of LCIS in major ducts. All this stuff is LCIS. And even here you can see that between these neoplastic LCIS cells, there are some darker nuclei. So these darker nuclei are the native ductal epithelial cells. So although a lot of them have been pushed to the surface, some of them get entrapped by between these proliferating LCIS cells. And if these look unusual, like, I mean, here it is pretty classic appearance, but sometimes lobular carcinoma in situ may have a little unusual morphology. The cells can be larger, they may have more prominent nucleoli and stuff like that, right? So when they colonize a duct, a benign duct or a duct which is hyperplastic, then the confusion happens, and that is where the interpretation of E-cadherin is important. One should not consider that the positivity of E-cadherin somehow suggests LCIS, DCIS mixture. So that assessment has to be morphologic. You have to be satisfied that whatever is staining with E-cadherin are really neoplastic cells. Okay, so the stain is not going to tell you that. That determination has to be made on morphologic grounds. Now, once in a while we all kind of tend to accept that Pagetoid extension equals LCIS involvement of a duct, right? I mean, that is what we learned as undergraduates, and maybe, even like most of the time, maybe our attendings have told, yeah, in the beginning, of our training, they may have told, yeah, so LCIS has Pagetoid extension. But you have to remember that even DCIS may involve a duct in a Pagetoid fashion. I mean, that certainly happens. That is how the Paget's disease, right? I mean, the term has happened because that is how the DCIS cells creep along the lactiferous ducts and go to the skin surface. So And when often that may not be a problem. Why? Because DCIS will look very abnormal, right? I mean, cytologically, the DCIS cells will stand out, and we will have no difficulty in making the diagnosis. Yeah, this is DCIS, which is spreading in a Pagetoid fashion. But every now and then, the very low-grade DCIS may also colonize the ductal walls, and it may create some confusion. And that is where you can use Iketherin stain. Iketherin stain, the resolution power of Iketherin stain is very good, actually. I have seen examples where a single duct may be involved both by DCIS and LCIS. And the Iketherin stain will elucidate that for you. It will show you the cells that are ductal, which morphologically, again, you will have a sense that, yeah, these are, that is why to begin with, you will be asking this question, whether there is involvement by both ductal, DCIS and LCIS. So the stain will only help you confirm what you already had suspected morphologically. So there is no difficulty in terms of the resolution power with Iketherin stain. It's only the problem happens how we interpret the staining result. Now, occasionally, very minimal kind of in situ carcinoma, DCIS kind of thing, low grade, may involve some few ducts in a biopsy, small ducts. And then the question will be, I mean, you will probably do Iketherin. I mean, you should do Iketherin anyway. If in a biopsy, all that you see is just Pagetoid kind of spread along duct wall, because in LCIS, you want to see acini, right? Those telltale small acini that group together. This is the picture that we have right from our medical school days of what LCIS is like. So if on the other hand, in a biopsy, all you see is like, ducts, and they have some sort of Pagetoid involvement by neoplastic cells. Now, while that could be a presentation of LCIS, it's a good idea to do Iketherin stain, because this is an unusual presentation, right? So the Iketherin stain will tell you that this is not pure LCIS. So in that case, you can then, while you may still not want to call these small foci as DCIS on core biopsy, you don't want to overreact to anything. You can suggest that, there are these small ducts which are involved in a Pagetoid fashion by atypical cells that show ductal differentiation and a staining pattern, supporting staining pattern with Iketherin and P120 stains. So this appears to be an atypical ductal proliferative process. And depending on how much it is, you can then go on to say that in this material, these changes are suggestive of ADH. However, a final determination will be made on excision. Okay. So I'm just going to let this phone ring. So just bear with me. I'll not answer this phone. So this noise will be there for a few seconds. Okay. So that was that. So in those cases, when they do excision, you will have more material, and then, hopefully the picture will become clear. Now, the reason why I'm emphasizing this is that if you just call like that on core biopsy as LCIS, now depending on what the imaging findings are, sometimes if the imaging is not really that impressive, a radiologist might interpret that as, okay, this is some kind of incidental LCIS for which no action may be needed. If there is a mass lesion or speculated thing or a lot of calcifications, then in those cases, the radiologist will recommend excision anyway. So not to leave any room for any confusion and all, this is how, it is best to kind of deal with those kind of, these are all rare things. You probably, if you're not doing a lot of breast pathology, the chances are that you might not run into this. And I think one of the things that I tell the fellows and residents is that when you have something unusual, you should not jump to make a diagnosis. Just the first thing to do in these situations is order levels, because levels allows you to buy time and cool off, things, so that you don't rush to any judgment, and then show the slide around, and so at least you have more than one person along with you, in that interpretation exercise. And if there is no resolution, no matter what, if the situation calls for it, it's better to send such materials, to any breast person and let that be his or her headache, Okay, so let's go to another picture. Okay, so here is what we have learned, right, in our classic textbooks and all, what LCIS should look like. So this is our beginners LCIS. This is the classic LCIS. Now, in some literature, old books, perhaps you may read about type A and type B of LCIS. So this would qualify as type A, right? The very small cells, uniform, The type B is made up of larger cells. So that is type B. Nowadays we don't make much a big deal about it, unless you are thinking about something like pleomorphic LCIS or florid LCIS. So that is the so-called special type. But between type A and type B, at least at Memorial, we don't make that discrimination. If we think something is classic LCIS, we will just say. If it appears to be unusually large, the cells, we may say that the cell size appears to be larger than usual, but it has no special significance unless the setting is that of florid LCIS or pleomorphic LCIS. Otherwise, classic remains classic. So all this is the so-called type A classic LCIS. Now, while we are talking about LCIS, in a core biopsy, it's very important to remember one thing. If you see a lot of LCIS in a core biopsy, and certainly if you see unusual type of LCIS, the florid or the pleomorphic LCIS on a core biopsy, please look at all the cores and also the fat in the biopsy very carefully, because whenever you have extensive LCIS or the unusual types of LCIS, that is when there is a possibility of associated invasion. This kind of isolated LCIS, this is not even necessarily regarded as a kind of cancerous thing, right? It is considered like a risk factor for future cancer development. So that is why nowadays, just for some isolated LCIS on core biopsy, they don't do any surgery, because the whole breast may have small foci like this and you will never get around it anyway. And there is not much risk involved. But of course, in that other situations, generally speaking, they will be associated with a mass or calcifications. The picture will be different. Now that, of course, you will have access to that if you know the imaging findings and if you are working closely with a radiologist. Now, if you are in a private practice, solo practice, or only in a small group, the communication between a radiologist and a pathologist may not be ideal, because there may be too many cooks involved in the process. There is an ill-trained surgeon who is dealing with patients, and then not sufficiently sophisticated radiologist reading the images and all. I mean, I'm not trying to belittle anything. I'm just trying to be realistic because this is the world we live in. So that's why one should, as a pathologist, especially doing breast biopsies, we should try not to make any diagnosis unless it is absolutely straightforward without having all the clinical information available to us. Because at least in my experience, the mistakes that I have made have happened when I have allowed myself to deny access to, clinical information. So it's less often that mistakes happen because we don't see what we are supposed to see in a slide, right? I mean, if there is something difficult, it's difficult for everyone, but at least we will know that, oh, this is something difficult that I'm seeing. The mistakes happen when we don't, with the unknowns, actually. That is where the mistakes happen. And in these discussion sessions, I will harp on this a few more times as we talk about phyllodes tumor and things like that. But anyway, not to belabor this further, I was just trying to tell you that in core biopsies, if you see unusual presentation of lcis, either extensive lcis or the special types of lcis, look very carefully all the tissue because there may be very subtle evidence of invasion. And the problem with lobular carcinoma, invasive, is that the cells, as we know, right? I mean, they don't form like big clusters or clumps or like that. They can be very single cells and very low grade, right? And when they sit between the fat adipocytes, they may just mimic, like maybe there is some fat necrosis or something like that. But in fact, that may be the subtlest manifestation of invasive carcinoma. And I have seen this happen in consultation. I have received biopsies from outside where more than one person have looked at the biopsies and they have called it lcis, but there already in that specimen there was evidence of invasion. So no need to go very crazy about this, but just keep this at the back of your mind. I think we may have seen this slide before. We saw this yesterday, in fact. So this is really the mixed dcis, lcis, right? You will be able to identify the two separately. This will be your morphologic diagnosis, right? So these are all lobular, and then you will clearly identify the ductal component. Now here there is no need to do ecadherin, right? I mean, if you want, you can, and that will confirm your morphologic impression. So this is a beautiful example of, how they can collide. I mean, using such words, collide and all, probably may not be a very scientific way of talking things about, because this may be an example of cell differentiating in two different lineages, right from the word go. So they share a pathway, right? There is a low grade pathway. So that is how, lobular carcinomas, low grade ductal carcinomas and all, they all share the molecular lineage. But we do use that term collision, right? So this is one such example. You actually are seeing both the things happening in the same unit. And like there are areas where it seems like it's pretty much almost exclusively ductal. And then there are areas where, so there is like some kind of zonation. So the two, it's like a weather system, right? There is a wave cold front coming from here, and then there is a warm front. And somewhere they just kind of, mix. So a nice example of collision. Okay, so while we are at it, so now you may have recognized, right, that these are much larger, right? I mean, that is because they are colonizing bigger ducts. They are not small acini necessarily. Oh, I think we did this already. Okay. Okay. So yeah, so this is a nice slide which shows invasive lobular carcinoma. And then it also shows LCIS. Now there is something unusual about this LCIS. I mean, first of all, these acini are quite big. So this is not what we see in a typical LCIS. But here it doesn't matter because there's already like frank invasive. So we are not going to spend a lot of energy on trying to dissect this. But the unusual forms of LCIS will present like this, the so-called florid LCIS. The acini will be large. In fact, you may get necrosis in some of these large spaces. And you may also get calcifications. Classic LCIS may get calcified, but more often the unusual LCIS is associated with calcifications. And again, you can see that here the LCIS is involving in some way already a hyperplastic duct. Now imagine if these cells were bigger, right? Like, for example, in some of these, there seems to be like two types of cells, right? I mean, these darker ones appear to be smaller than these bigger ones. I mean, all of this is LCIS. If you do e-cadherin, it will confirm that. My point is that when these somewhat more atypical looking cells, when they involve a pre-existing hyperplastic duct, then it's easy to make the diagnosis of dcis. Like, that error can happen. So, I mean, a lot of these things we only learn from experience and as we go along. I mean, we all have to start someday somewhere. But I think if you have the basic understanding of what are the features of LCIS, then even when the cells tend to be larger, you will kind of recognize those features. So for one thing, LCIS, they tend to be discohesive, the cells. They seem to fall apart. And that feature will be present in even the unusual situations. They will kind of stand out separately from the ductal cells. And then, of course, when you do e-cadherin and P120 stain, you will recognize that, there are a lot of cells that are not staining with these immunostains, and they correspond to the LCIS. Now, there, of course, will be a lot of ductal cells in a hyperplastic duct, but as I said earlier, the morphologic determination that these are benign will help you kind of ignore all that noise. So this is just like a UDH kind of duct. Look at how these fenestrated spaces are at the periphery, but it's much of it is involved by LCIS. That's why it's looking so busy and so abnormal. Okay, so type A and type B. So something like this, this is how you could argue that this is perhaps what was in the minds of those people who call this as type B and versus type A and all that. Oh, there is only one frame.
Yeah.
That's it. Okay. So I'll just talk a little bit about the unusual or the special types of LCIS. Unfortunately, we don't have a picture of that here. So Akanksha, I think is it possible that maybe I can show like a PowerPoint presentation
Of course, of
in a
course. I mean,
limited
if
way,
you
so I
have it,
can, so
yeah,
depending
yeah,
on the topic of discussion that we have, maybe I can pull something, and then share that in
yeah,
the,
yeah.
so that way, we can discuss those.
That will be fantastic. I mean, if you have slides that you want to show, if you have PowerPoint, feel free to show that.
Yeah, yeah. So I think we'll try aim to do that, in
Yeah, yeah.
as we go along. So anyway, I mean, for now, so what is unusual or special type of LCIS? So there are two broad groups, right? One is nowadays we use the term florid LCIS for one of them. I mean, previously for this same thing, people used to call LCIS with marked acinar expansion and central necrosis. That was also the term that was used for the florid LCIS. And then the other, of course, is the pleomorphic LCIS. Now, pleomorphic LCIS is rather rare in its pure form. Pure, just pleomorphic LCIS is rather rare. So why is it rare? My theory is that it probably is rare because pleomorphic LCIS early on in its life history will acquire this potential to become invasive. So it will kind of transform, or it will begin like with micro invasion and then obviously overt invasion. So given sufficient amount of time, unlike classic LCIS, which will remain in LCIS mode or senescent mode for years and years and years, the pleomorphic probably has a much shorter life. It will very quickly become invasive. Now, having said, and that is why it's more important for us in a core biopsy when you see what looks like pleomorphic LCIS only to look for any subtle evidence of invasion. Okay. Now, because of that, because of the fact that pure pleomorphic LCIS is rather rare, there is not much literature on this topic. You will not find too many studies that go into the what is the prognosis and what happens, and is this the same as classic LCIS? Is this more aggressive than that? How does it differ from dcis? So one would like to get answers to all these questions, right? Because if we have definitive answers to these questions, then from the word go, pleomorphic LCIS will be managed differently from the classic LCIS. We do have evidence to suggest that they tend to be aggressive. I mean, obviously, there is no secret about that. The cells themselves are screaming out that I am malignant. So obviously, they are going to behave in a malignant fashion. But there is no definitive conclusive data so for all these big committees to come out with recommendations. So what to do with this, whether to radiate and stuff like that. So the other problem with pleomorphic LCIS and the paucity of data is the fact that certainly up until we got E. cadherin stain, most of these pleomorphic LCIS cases were getting diagnosed as dcis, and they were being treated as dcis. So the older literature, of course, will not, there may not be any term such as pleomorphic LCIS because they only recognize one type of LCIS. Of course, there were astute pathologists. It is not that this is something, only E. cadherin has brought this terminology. Of course, there were astute pathologists. Like Rosai and all, they didn't need, today, Rosai will say, what are these, fools? Why do they need all these P something and P something to make diagnosis. He would make diagnosis. From my first-hand experience with him, I can tell you, he would make diagnosis, morphologic diagnosis by looking at Kodachomes of gross pictures. He would say, this is angiomatoid MFH. And that is what the slides would then show, you know. So, but anyway, so the lot of this literature has come about on pleomorphic LCIS after the advent of E-Catherine era. That is another reason why the data are limited. But I'm sure, you know, in the years to come, we will have good enough data that will lead to some kind of definitive guideline. But even today, we will report pleomorphic LCIS or florid LCIS if it is close to the margin or at margin in surgical specimens, because they will probably go back, although not all surgeons will do that. There will be some surgeons who will go back and try to clear those margins. And not to forget that even these foci of pleomorphic LCIS that are near the margin, beyond the margin, there may be subtle invasion, because we know that invasive lobular carcinomas can be multifocal, multicentric, and so on. So now, similarly, when it comes to the florid LCIS, these also are more likely to be associated with subtle invasion. So on core biopsies, we have to be mindful of that. And certainly from that picture that you saw of the invasive lobular carcinoma with those big, so I mean, you know, the chances are that from the word go, there was like unusual type of LCIS in the setting of which that invasive lobular carcinoma happened. Okay. So,
Dr. Giri,
yes.
I have opened the florid LCIS and pleomorphic LCIS pictures from Google. Can I quickly share the screen and you can
Yeah,
that?
please. Do you want me to stop sharing?
No, that should not be needed.
Oh, okay.
You can see the screen?
Oh, yes, beautiful. Yeah, great. Okay, nice. Okay. So here we are, right? I mean, this picture here.
Yeah.
You can see my arrow, right? Yeah, I can see.
No.
Also, yeah. So here, this is necrosis and calcification. So this is what we used to call earlier on as, like, you know, LCIS with markedly enlarged acini and central necrosis. So that is that. And here is pleomorphic LCIS. Look how these nuclei are ugly. And they look kind of plasmacytoid, right? Some of these, look at the nucleoli. I mean, if you haven't seen some of these cases of pleomorphic LCIS, it's not surprising that you would think that this is DCIS, right? I mean, this happens all the time. And certainly in the old days, you know, all this were being called as DCIS, and they were treated as DCIS. It's only with E-Catherine, and look at how mitotically active. So, I mean, it would not be surprising that the behavior of this is something like DCIS already, right? And that maybe it's a good idea to treat them as DCIS. But we don't do that, at least for now. And there could be a lot of reasons for that. For one thing, I don't see an image here of that, but I can certainly show you later on, you know, from my own collection, an example of pleomorphic LCIS arising from the same acinus, which also has classic LCIS. So probably something happens clonally, like, you know, molecularly, that triggers the transformation from classic to pleomorphic LCIS. So when there is a lot of pleomorphic LCIS in a specimen, or some pleomorphic LCIS in the specimen, you will oftentimes see that there is also associated classic LCIS, because it's kind of a continuum. So there may not be any need to actually, revise the margins and all, because for all the adjacent stuff that is there next to the pleomorphic looking LCIS is probably classic LCIS. So these are all very difficult, unless we have definitive studies. There are all these things which would have to be looked into, before when a study like this is done. And certainly no such study should be done without the involvement of a pathologist, because these are the questions that only a pathologist can ask. So we'll see. There was a study done here at Memorial years ago by Dr. Terry King, one of our former breast surgeons. And she only had like 8 cases. I mean, she had a big collection, hers was the biggest single institutional collection of pleomorphic LCIS. And yet she only had like 8 cases of pure pleomorphic LCIS where she had follow-up data. And 3 of those recurred. So I think her conclusion was that, yeah, these are aggressive and maybe they need, more aggressive management, but how much can you do with 8 cases, right? So, okay. So maybe let's stop with LCIS discussion and go back to other things. So
you'll have to share the screen, yeah.
Oh, I have to share it again. Okay.
Yeah.
Okay. So what do we want to discuss? Let's put in papillary. Shall we discuss papillary carcinoma?
Sure, yeah.
Okay. So let's look at this core biopsy, because there are a couple of core biopsies. Because how we word our report in core biopsy is important. And what you will notice, and I'm sure you already know this, is that when there is a papillary lesion, papillary carcinoma in a core biopsy, they tend to be fragmented like this. Unlike our other lesions, right, which will remain intact in the same core, you will see the process like continuous. Whereas in papillary lesions, and certainly papillary carcinomas, it tends to be fragmented. So that's something which I always mention in the report, that fragments of papillary carcinoma. Now, I don't know in this core biopsy whether this is going to be invasive or not, right? So instead of trying to say that there is no evidence of invasion or this is papillary dcis, in a situation like this, the best way would be fragments of papillary carcinoma, and next line would be due to fragmented nature, invasion cannot be assessed. And that's fine. On imaging, probably, they have a better idea because they would have seen this as a cystic mass or something like that. So they probably, if it is like an overtly invasive type of papillary carcinoma, then it would not look like a cystic or a nodular mass. It will look like a spiculated or something along the lines of an invasive kind of process. The assessment of invasion, unless there is frank invasion that you can see in the stroma, that I think should be left for the surgical specimen. So a lot of these examples here. See how fragmented? I mean, this is the scenario, like you will always see these fragments. Okay. Okay, so now this is an excision specimen, right? So in the biopsy, this is what we saw. We saw the core of the thing. with something on the side, right? Now, depending on how and where the sampling was done, you may or may not see definitive invasion in core biopsy. Therefore, it's not a good idea to say anything definitive about whether this is going to be invasive or not. Here, for example, a lot of it is very well defined, right? So this is like papillary, or you would think like papillary dcis, right? But then when you go here, now these areas look different, right? While some of it is still kind of enclosed within this outer like duct wall, there is stuff that is kind of going into the stroma. So this is already looking morphologically suspicious for invasion. And the invasion in papillary carcinoma can come in various forms. One form would be that you have like a nice dcis-like thing, and then a little bit away, there would be conventional invasive carcinoma. So those cases are not difficult to interpret, right? Because now you are seeing clearly what you recognize as invasive ductal carcinoma. In other situations, the invasion may be like the membrane here, the basement membrane here being broken, and then, like an earliest infiltrating kind of, clusters coming out. And then there may be reactive changes in the stroma. So that when that is very minimal, you can then say that, okay, this is papillary DCIS with foci. I mean, depending on your comfort level and confidence level, you would say with foci suspicious or with foci of micro-invasive carcinoma. That is how the micro-invasion will look. Now, in some cases, because this is like by pushing, right? I mean, this is constantly trying to push. So at some point, maybe this, basement membrane gives way, and then now this is now invading into the stroma. So if you do a myoepithelial stain in this scenario, right, it may or may not help. If you see, for example, a good myoepithelial layer everywhere else, and then it is totally absent here, then that will support your assumption that there is invasion, right? And that would be like an objective. Nobody is going to question that. But sometimes the problem will be that even here you may not see any, and this happens like in encapsulated papillary carcinoma anyway. So if you don't have any myoepithelial layer here, then you don't have much of a ground to say that because I don't see any myoepithelial layer here, therefore it is invasion. So one has to make that determination of whether this is invasive or not morphologic. If you get lucky, a myoepithelial stain may help you objectify that, but it may not. But you can. So again, in these situations, certainly when you don't have much experience, then it is a good idea to show the case around, before calling some invasive or like that. I mean, to me, this is already invasive. This has already infiltrated the stroma. So there, the manifestation of invasion in papillary lesions can be in many forms. It's the same thing here. I think these are the same exact images. Okay, so not many pictures. If we put encapsulated papillary carcinoma, let's see if we get anything. we don't have, unfortunately, so that's okay. Okay.
Can you just type papillary and see what it comes like? Just
Okay.
papillary.
That's what we got, I think, when we.
There's a
Oh,
solid papillary.
okay. So we got solid papillary. Okay. So this we discussed on, I think, on the first day, right?
Mm-hmm.
So you can see again, for those of us who were not there on day one, you can see this kind of jigsaw kind of arrangement, right? This is very typical of solid papillary carcinoma. And when you go higher power, you will see some attempt towards these, fibrovascular cores. And as is seen here, oftentimes solid papillary carcinoma, the tumor cells will show this kind of spindling. And also many times they show neuroendocrine features. So this can be quite contentious, whether this is invasion or not, but really to call something, you have to have unequivocal invasion. I mean, is this unequivocal invasion? I mean, it certainly seems like that, that it's trying to go into the fat. I mean, here it's in the fat. So, I mean, these kinds of problems you should not try to resolve in a hurry. You should take your time, take other people's opinion. I mean, here it looks to me there is unequivocal invasion already. I mean, there is no way this is non-invasive. This is going, I mean, these are all nests of tumor cells, right, which are growing between fat cells and infiltrating. So it's already, so there is invasion. I mean, this is solid papillary carcinoma with unequivocal invasion. But if you feel uncomfortable, you should just send the case out. I mean, this to me is already invasive. There is no question in my mind that this is invasive. So these are difficult areas. So when you have encounters with like, the encapsulated papillary carcinoma or solid papillary carcinoma, and, instead of just, like making a diagnosis anyway, maybe, you can just give the case to someone else and let them decide what the hell it is. Now, by definition, encapsulated papillary carcinoma, they are low grade. Okay. And that is why it's probably okay to treat them as dcis. In the literature, you will find, I think there is at least one study that I am aware of where they have come out with the term high-grade encapsulated papillary carcinoma. So in that study, of course, they said that these tend to be more aggressive, right? So what would be the analogous situation? It would be like low-grade DCIS versus high-grade DCIS, right? Something like that. So the authors, I don't think were trying to make the point that high-grade encapsulated papillary carcinoma should be treated like invasive carcinoma, right? They were just trying to say that this is the high end of the spectrum. Now, again, the high-grade encapsulated papillary carcinoma will be rare, right? Because anything that is high-grade will probably have the potential to infiltrate early on in its life cycle. Whereas the low grade will tend not to invade and will just grow in an expansile fashion, right? Like a balloon, it will keep growing and still remain like an in situ lesion. But the high grade ones, we don't see that commonly because, by the time we see them, they have already become invasive. So we can again talk for in the benefit of people who were not participating with us last time when we talked about the use of myoepithelial stains in the setting of encapsulated papillary carcinoma. So these stains will show you that the encapsulated papillary carcinoma have no myoepithelial layer. But that should not be the ground for making the diagnosis of invasion. So you have to remember that when something expands, so let's say in the beginning, that lesion around its duct, it had 50 cells, right? And let's say that it was like 1 millimeter in diameter, the entire duct, and it had 50 myoepithelial cells around it. Now, in that situation, if you did the myoepithelial stain, it will show, right? It will light up the myoepithelial layer because you have a small area where there is enough number of myoepithelial cells that the stain is going to pick up. Now, imagine if this keeps ballooning, right? And now you have like a 5 centimeter lesion, but the myoepithelial cells are not growing, right? Because they are not neoplastic. So those 50 cells are now going to be spread and they are going to be pushed and they will become smaller. Smaller in the sense they will get thinner. But the number of cells is unlikely to grow unless there is some kind of crosstalk between the neoplastic cells and that is promoting the myoepithelial cells. So that may happen actually, but there is also a chance that that number of myoepithelial cells remains static. So now over a wider space, these thinned out myoepithelial cells will be spread. So they may, three-dimensionally, when you look at it, you have to always think three-dimensionally, although we see only 2 dimensions on our sections. Any surgical pathology process has to be thought of as a 3-dimensional thing. So 3-dimensionally speaking, there is a chance that you may not be able to demonstrate any myoepithelial layer in a portrait that you are looking at of an encapsulated papillary carcinoma. So mere inability to see those myoepithelial cells does not mean that this is an invasive carcinoma. Okay. So there was some confusion and some controversy, when some of the studies using myoepithelial stains and noting the absence of that tried to make the argument that because there is no myoepithelial layer, these are all invasive carcinomas. So we had this absurd situation where people started sending, for oncotype and all, because something was 2 centimeters or 1.5 centimeters and it was encapsulated papillary carcinoma, but it was considered to be invasive in the absence of any myoepithelial layer. So, but of course, the WHO has come out, and even in this new edition, they still maintain that it is in the absence of any different, data or any evidence contrary to what we have now. It is probably a good idea to manage these lesions as just as we would manage dcis. Okay.
I have a question. So,
Yeah.
what about the opposite situation? For example, in that papillary DCIS, when you had a small area of invasion, or for example, in solid papillary carcinoma here, where you have periphery, small area of like morphologic invasion. If you
Right.
have persistence, like if you have intact myoepithelial stains in there, would you rule the invasion out, or would you just base it on morphology?
Oh, well, I mean, if you have a good layer of myoepithelial cells, right, then of course, this is unlikely to be invasive.
Right.
I mean, I doubt very much that the situation that we saw here, the myoepithelial cells will be present in those nests. But
Right.
but if you see a good myoepithelial layer, it's best. I mean, that you should not just push ahead anyway, and call it invasive.
Right.
Maybe if it still looks funny to you and you still think that maybe there is some invasion, maybe it's probably let a breast pathologist take a look and kind of weigh in on that.
Right. Right. Got it. Thank you.
Okay, so I think we are close to 5 o'clock. So maybe this is a good time to end our session today, and we will come back tomorrow.
Sounds like a plan. Thank you very much. This
Sure.
was a great session. I always am intrigued by the papillary lesions, and they sometimes, yes.
No, these are hard. These are hard, I mean, in fact,
Yeah.
let me tell you a funny story. A pathologist at MGH, Dr. Kerner, some of you may have heard his name. He's also a breast pathologist.
Mhm.
So whenever he gives a talk on papillary lesions, his first slide will used to be, this session is for adults only. This movie is for adults only. Okay, so on that
All
note, we
right.
will stop. Yeah,
Thank you very much, Dr.
sure.
Giri. Thank you. Have a good day.
Yeah.